Assalamu alaikum. How are you, everybody? I am Dr. Muhammad Gamal, lecturer of cardiology. Today we are going to speak about approach to a patient presenting with shortness of breath. The internal learning outcomes of this lecture are to know the main causes of dyspnea, to perform a good analysis of the patient's dyspnea complaint to reach a provisional diagnosis, and to know the classification of dyspnea, mainly the NIHA classification, and to differentiate between cardiac asthma and bronchial asthma, and finally to recognize the definition of orthopnea and PNDs, or paroxysmal nocturnal dyspnea. First of all, definition of dyspnea. We all know that at rest we do not feel our breathing. So when someone gets to feel his own breathing, this is always or most of the times this is abnormal. So dyspnea means unpleasant awareness of one's own breathing. There are many causes of dyspnea or of shortness of breath. The main causes are cardiac conditions, chest conditions, and other causes. Cardiac conditions like what? Like heart failure, like valvular heart diseases, including mitral stenosis and mitral regurgitation, ischemic heart disease, what we called angina equivalent. If we have any pericardial diseases such as pericardial effusion or constricted pericarditis, if the patient has acute pulmonary embolism or has pulmonary hypertension, those are the main cardiac causes that can cause dyspnea for the patient. There are other chest causes such as asthma, COPD, what we call obstructive pulmonary diseases, and restrictive pulmonary diseases such as interstitial lung diseases and other pleural diseases. There are other non-cardiac, non-respiratory causes of dyspnea which are very important, such as anemia, anxiety, panic attacks, renal failure, chest trauma, kyphoscoliosis, and obesity. Okay? Some of those patients will present with chronic dyspnea, others will present with acute shortness of breath or acute dyspnea. What are the common causes of acute dyspnea? We have acute pulmonary edema, acute pulmonary embolism, acute severe asthma, acute pericardial effusion, pneumothorax, pneumonia, panic attacks, and so on. Okay, so a patient comes to the ER or to the outpatient clinic complaining of dyspnea. How can I approach this patient? First of all, I have to analyze the patient's complaint. I have to ask about the onset of the patient's complaint. Is it acute? Is it chronic? Is it gradual? And ask about the course of dyspnea. Is it progressive, regressive, intermittent, persistent, stationary, and so on. Also, we have to ask about the duration of dyspnea, meaning that if we have a dyspnea that has been with the patient for months or for years, this is more or less a clinic case. Unlike a patient presenting with acute severe dyspnea of 2 to 3 hours duration, this is an acute case that has to be managed urgently in the ER. We have to ask as well about what increases and what decreases the patient's complaint. What is the aim of those questions? The main aim is to try to reach a provisional diagnosis. What is the cause of this patient's dyspnea? Okay. For example, if the patient has ischemic heart disease, his dyspnea will increase with exertion, okay, and will be relieved at rest. If a patient has heart failure causing dyspnea, he will have his dyspnea increasing when he lies flat, what we call orthopnea. Okay. We have to ask as well about associated symptoms, which is very important. What are the examples of associated symptoms which may be happening with the patient's dyspnea? We might have orthopnea and PNDs pointing to a cardiac cause, mainly left-sided heart failure or mitral valve disease. We might have chest pain pointing to ischemic heart disease. Associated palpitations may point that the patient has arrhythmias such as atrial fibrillation, which may be a cause of dyspnea. Other symptoms such as ankle swelling, which may be point as well that the patient has evidence of right-sided heart failure. If the patient has chest wheezes, may point that the patient has bronchial asthma, although it may occur as well in patients with cardiac conditions, what we call cardiac asthma. If the patient has cough and fever, this may point that the patient has a chest infection or pneumonia. If the patient has hemoptysis, this may be an indicator of acute pulmonary edema or acute pulmonary embolism. What we what we have said before a while, that in a patient with heart failure, it is very important to ask about dyspnea, PNDs, and orthopnea. In addition, we have to ask about risk factors of ischemic heart disease, such as diabetes, dyslipidemia, smoking, positive family history, which may suggest an ischemic cause of the patient's dyspnea. As we said, if the patient's dyspnea increases with exertion, this might suggest that the patient has angina equivalent, which suggests ischemic heart disease. Okay, what do we mean by PNDs? PNDs is an abbreviation for paroxysmal nocturnal dyspnea. Okay, how do we know that the patient has paroxysmal nocturnal dyspnea? We have to ask the patient directly. Do you sleep well at night? Do you have any episodes when you have to wake up 1 to 2 hours after sleeping because of dyspnea, and you have to run to the window to take your breath? This may be an indicator that the patient has paroxysmal nocturnal dyspnea, which may indicate that the patient has left-sided heart disease. What is the mechanism of paroxysmal nocturnal dyspnea? Mostly it occurs due to fluid redistribution from the lower limbs to the lungs due to increased venous return. As we can see here, this is the patient lying flat in bed at night. 1 to 2 hours after sleep, the patient has to sit acutely, and he complains of severe dyspnea and respiratory distress. This may be associated with cough and frothy sputum. As we said, there is fluid accumulation in the lower limbs in the recumbent position. When the patient lies flat, there is fluid redistribution to the upper parts of the body. There is an increased venous return, which leads to increase in the left atrial pressure and pulmonary venous pressure, causing pulmonary congestion. Okay. There are multiple causes of paroxysmal nocturnal dyspnea. The most common causes are heart failure, pericardial or heart failure, ischemic heart disease, mitral valve disease, atrial fibrillation, cardiomyopathy, and so on. Also, we have to differentiate between cardiac asthma and bronchial asthma. How to differentiate between them? We have history, examination, investigations. First of all, by history, the age of a patient with cardiac asthma is mostly middle age or old age due to long-standing heart disease, while a patient with bronchial asthma, mostly he is a young patient, and he has a history of repeated attacks of dyspnea, and this may be precipitated by some aggravating factors, such as like smelling dust mites, eating certain allergens, and so on. On the other hand, patients with cardiac asthma, he might have a past history of valvular heart disease, rheumatic heart disease, risk factors for ischemic heart disease, or he might be a non-ischemic heart disease patient. Okay, when we analyze the symptom of the patient, we will find that the patient with cardiac asthma, he might have frothy sputum, while a patient with bronchial asthma, he might have associated thick sputum, and wheezes are more common with bronchial asthma than with cardiac asthma. The timing of the attack, as we said, the patient with cardiac asthma, he might have the attacks after 2 hours of sleep, while a patient with bronchial asthma, he usually has the attacks in the early morning. How does the condition get relieved in patients with cardiac asthma? Once the patient sits up, his symptoms get better gradually, while a patient with bronchial asthma, even when he sits up, the symptoms do not get better unless he uses his inhalers or his bronchodilators. On examination, as we all know, when a patient with cardiac asthma gets cardiac examination, he will mostly have a positive finding, such as acetyl gallop, such as an apex that is shifted down and out. We might hear a murmur of mitral stenosis, mitral regurgitation, or any other valvular lesion. While a patient with bronchial asthma, his cardiac examination is usually normal. As regards the chest examination, which is very important, in a patient with cardiac asthma, he will have fine basal crepitations and he may have inspiratory wheezes, while the wheezes in patients with bronchial asthma, as we all know, they will be expiratory wheezes, and there may be crepitations, but they will not be fine crepitations, they will be coarse crepitations, and they are less than in patients with cardiac asthma. Okay? So the main finding in chest examination of a patient with cardiac asthma is fine basal crepitations, while the main finding in patient with bronchial asthma is expiratory wheezes. When we perform a chest X-ray for the patient, in a patient with cardiac asthma, we will find cardiomegaly, we will find congestion, whether perihilar or or between the lung lobes, what causes what we call curly B lines. While the chest X-ray of a patient with bronchial asthma will show lungs hyperinflation or evidence of consolidation. The ECG of a patient with cardiac asthma may be normal or abnormal. When it is abnormal, what we can find? We can find evidence of old myocardial infarction or ischemic changes. We may find bundle branch block. We may find evidence of chamber enlargement, especially if the patient has a valvular lesion. While the ECG of a patient with bronchial asthma might be completely normal or may show evidence of sinus tachycardia or right ventricular hypertrophy. As we said, orthopnea means that the patient cannot lie flat in bed. When he lies flat in bed, the patient gets severely dyspneic and distressed, and once he sits up or stands, the symptom starts to improve gradually. So many heart failure patients have to sleep in a sitting position or may use more than one pillow. As we can see, this patient, he has to sleep on four pillows to be able to get into deep sleep. Okay, this may be a symptom that the patient comes complaining of, or it may be a sign that the physician elicits when he asks the patient to lie flat in bed for examination. The patient cannot tolerate this position for a long time. Okay, then we come to the classification of dyspnea. There are many classifications. The most common used is the New York Heart Association classification of dyspnea. We have four grades, 1 to 4. As regards NIHA class 1, it is very mild dyspnea. The patient is not dyspneic at rest. The patient performs his ordinary physical activities, his daily activities without any limitations. Okay. Then we come to NIHA class 2. NIHA class 2, the patient as well has no symptoms at rest. He performs his daily physical examinations with his daily physical activities with no limitations, but he has mild symptoms during performance of this physical activity. Okay. Then NIHA class 4, NIHA class 3, the patient is no longer able to perform his daily physical activity due to limiting dyspnea. We mean that dyspnea limits the patient in performing his daily physical activities. Then NIHA class 4, the patient is dyspneic at rest. The patient comes to the clinic or to the ER, he is dyspneic at rest without any form of exertion. Okay, so the only patient who has dyspnea at rest is the patient with dyspnea NIHA class 4. This is the most severe form of dyspnea. We have performed history and examination of patient with dyspnea. Then we come to investigations. When we come to investigations, as we all know, we can classify them into laboratory investigations and radiological investigations. As regards laboratory investigations, we can do CBC for the patient. This can diagnose some sort of anemia, or if the total leukocytic count is high, this may diagnose that the patient has pneumonia or chest infection. We may perform as well thyroid profile and renal function tests. As we said, when we perform an ECG for a patient with dyspnea, we might find evidence of old myocardial infarction, arrhythmias like atrial fibrillation, chamber enlargement if the patient has valvular lesions. We can do as well a chest X-ray, as we said. We may find in a patient with cardiac origin of dyspnea, we may find evidence of perihilar congestion, curly V lines. We may find cardiomegaly, increased cardiothoracic ratio, or we may find evidence of a chest or a pulmonary cause of dyspnea, such as pneumothorax, acute pulmonary embolism. The shape of the wedge infarction, and so on. There are other investigations which we may do when we reach the provisional diagnosis. For example, if my examination and my history suggest that the patient has a cardiac origin of dyspnea or that the patient has heart failure, I may perform an echocardiography. If I suspect that the patient has pulmonary embolism, I may perform D-dimer and CT pulmonary angiography. If I suspect pneumonia or a chest condition, I can perform a CT chest. Okay, then we come to approach to a patient with acute dyspnea. If a patient presents with acute dyspnea, this may be an emergency condition, which we handle in the ABC approach. First of all, A, airway, and B, breathing. We have to check the patient's respiratory rate. If it is more than 24 per minute, or if the oxygen saturation of the patient is less than 90%, this is an emergency. The patient has to be admitted to the ER, okay, and even maybe admitted to the ICU or to the CCU. We have at first to secure the patient's airway, whether using an oral airway or an endotracheal tube if the condition is very severe, and if the patient's saturation is less than 90%, we have to give the patient oxygen, whether by nasal oxygen, oxygen mask, CPAP, and up to invasive ventilation. Then we have to perform rapid clinical assessment in the form of history, examination, and basic investigations. History, we have to analyze the patient's symptom, as we said before, and know the associated condition, because this may point to the cause of dyspnea and help me reach a provisional diagnosis. Then we perform examination. What is very important is general examination, vital data, arterial blood pressure, pulse, respiratory rate, temperature. We have to examine the patient's neck vein for jugular venous congestion, which may point out that the patient has acute heart failure or that the patient has cardiac tamponade. We have to examine the patient's lower limbs for bilateral lower limb swelling, which may point to that the patient has heart failure, or if we have evidence of unilateral lower limb swelling, that may suggest that the patient has acute DVT and that the cause of the patient's dyspnea is acute pulmonary embolism. As regards cardiac examination, as we said, we may hear an ST3 gallop. The apex may be shifted down and out, and we may hear a murmur of valvular lesions. The chest examination in this patient is very, very important. Why? Because we may find basal crepitations suggesting acute left-sided heart failure and acute pulmonary edema. We may find coarse crepitations which may suggest pneumonia. We may find expiratory wheezes that helps me diagnose acute severe asthma. We might have decreased air entry that might diagnose pleural effusion or pneumothorax. Basic investigations, we have to perform ECG, we have to perform chest X-ray, and we perform ABG. ABG is very important in this case to know the patient's oxygen saturation and diagnose if the patient has any form of respiratory failure, whether type 1 or type 2 respiratory failure. It may help me as well to check the patient's pH, if the patient has metabolic acidosis, respiratory acidosis, which may explain the patient's dyspnea. Then, after performing rapid history taking examination and basic investigations, we should have reached a provisional diagnosis, and we act accordingly, and ask for further investigations and further management according to the provisional diagnosis. Okay. For example, if the patient we have evidence that the patient has heart failure. If it is acute heart failure, the patient has to be admitted to the CCU, and we perform echo later on. If we suspect that the patient has massive pericardial effusion or cardiac tamponade, we should do an urgent echo, because if we diagnose cardiac tamponade, the patient has to undergo urgent pericardiocentesis. If the patient has angina equivalent, we should draw cardiac enzymes and check the patient's ECG, and if there is evidence of acute myocardial infarction, the patient has to be admitted to the CCU and undergo coronary angiography. Other causes such as pulmonary embolism, we have to admit the patient as well to the CCU and give whether anticoagulants or thrombolytics. If the patient has acute hemorrhage, this may not be diagnosed alone by hemoglobin, because in patients with acute hemorrhage, the patient's hemoglobin may be normal, but his hematocrit may be reduced. So if the patient has acute hemorrhage, the patient has to have packed the RBCs, and the cause of acute hemorrhage should be handled emergently. Finally, we have a classification for patients with acute heart failure. A patient with acute heart failure may be warm or cold, and he may be wet or dry. What do we mean by warm or cold? This refers to the patient's perfusion status. If the patient is well perfused, this patient is warm. If he is hypoperfused, this patient is cold. What are the signs that help me to know if the patient is hypoperfused or not? If a patient is hypoperfused, he will be oligoric. He will have cold extremities. He will have delayed capillary refill. The patient might have some sort of dizziness and mental confusion, and he will have narrow pulse pressure or weak thready pulse. Okay. If the patient has these signs, or most of them, this patient is hypoperfused. This patient is cold. If he does not have these signs, this patient is warm. Okay. The other term is dry or wet. What do we mean by a wet patient? A wet patient is a patient with evidence of volume overload, evidence of congestion, whether uh, left-sided elevated venous pressure, uh, the patient has orthopnea, paroxysmal nocturnal dyspnea, the patient has basal crepitations, okay, or the patient has evidence of right-sided heart failure, such as bilateral lower limb swelling, the patient has congestive hepatomegaly, the patient has congested neck veins, and so on. Okay, if the patient has these signs, this patient is a wet patient. If he does not have these signs, this patient is a dry patient. So our patient may be a warm dry patient, a warm wet patient, a cold dry patient, or a cold wet patient. The best of them all is a warm dry patient. Okay, this patient is adequately perfused. This patient is not congested. He does not have any volume overload. Okay. The second patient is a warm wet patient. This patient has good perfusion status, but he is congested. He has volume overload. This patient can be managed with diuretics, with a dose and route of administration according to the patient's degree of volume overload and congestion. The third patient is a cold dry patient. This patient is not congested, but he is hypoperfused. Mostly this patient will need IV supports to improve his perfusion status. The worst patient of them all is a cold wet patient. This patient is hyperperfused, okay, and he is congested. A congested patient must take diuretics. However, this patient is also hyperperfused, so he cannot get rid of the extra fluid in his body through his urine, because he is oligoric. So this patient is very critical. This patient has to be handled. May need respiratory support in the form of CPAP or invasive ventilation, most of the cases, and this patient mostly will need as well IV supports. Thank you very much. I hope it was a Nice lecture.